Hi, I'm Nupur Jhunjhunwala. I run the dental clinic called Toothwise and the sleep clinic called Somniawise. Here we do a lot of work around the airway, and today I'm going to be talking about how to fabricate an oral appliance which helps obstructive sleep apnea. As a recap, what does obstructive sleep apnea mean? It means the airway while sleeping gets partially or completely blocked, and the patient has low oxygenation, resulting in snoring, tiredness, and lethargy during the day, high blood pressure, high blood sugar, chances of cardiovascular and neurological issues, low immunity, hormonal imbalances, among other things. The decision to make a sleep appliance must come from a sleep medicine specialist or the patient's primary care physician. We as dentists cannot say that this person needs a sleep appliance just by reading the sleep study. Another thing I wanted to make clear is that reading a sleep study is an art which we need to learn. Don't take it lightly. Reading it does not mean only seeing the AHI and saying mild to moderate sleep apnea can be treated by a dental appliance. There are other parameters that need to be checked, like general health of the patient, comorbidities, and the severity, of course, of the sleep apnea. As dentists, we are very well positioned because we see the patient's mouth every 6 months. So the signs for sleep apnea is something that we can pick up, and then we can tell the patient to see a specialist. So collaborative work is what I would recommend when we are treating sleep apnea. So sleep apnea can be managed in a few ways. One is a sleep appliance, which is made by a dental clinic. The other way is to put positive constant pressure into the airway, which clears the airway out. And that is done by a CPAP. Or surgery may be recommended, which is done by ENT specialists or oral surgeons. Now, if the decision has been made to create a mandibular advancement appliance, what does this mandibular advancement appliance do? It gently moves the mandible forward, and that creates more space in the airway. So that is what we are trying to do here. We are bringing the mandible forward in a controlled, reproducible way so that the airway, the oropharynx, can increase in size. When the patient is in the supine position, the tongue and mandible don't fall back into the airway and obstruct breathing. This is the Snoreka Pro D. It's a mandibular advancement appliance. It keeps the mandible forward in a certain position determined by us. This is the upper appliance and this is the lower. As you see, there's a dorsal fin here that gets attached here and does not allow backward movement of the appliance. So this fixes the jaws in a certain position while sleeping. It is extremely comfortable once the patient gets used to it, and it does not allow the airway to be blocked by the tongue or the mandible. While fabricating a mandibular advancement appliance, it's important to have all three planes in mind: the sagittal, the coronal, and the horizontal or transverse planes, so that TMJ health and muscle health is maintained. For simplicity, in this demonstration, I'm only showing you the horizontal plane. This method should only be used for patients who do not have TMD. When we are doing all three planes, we need to use EMGs and joint analysis so that the final mandibular position is according to all three planes. So this is a George gauge. I'm going to be using this to determine the forward position of the mandible. Since we are only working on the horizontal plane, this is going to be sufficient. George gauge provides me with a controlled and reproducible forward position. And this position is going to open up the airway by gently bringing the mandible forward. So this is the George gauge we are using on the patient. There is a notch for the lower incisors and a notch for the upper incisors. Open, please. Bite. Okay. Now he's freely able to slide the mandible forwards and backwards. Slide back completely as much as possible. Here you can see the marking is on 5 when he slides back. Now slide your mandible forward completely, as much as it will go. Perfect. And this marking is at -5. So he has a range of 10 millimeters. We'll set the range at about 5 millimeters. We can advance the mandible by 50 to 70%. I like to advance it to 50%. After we advance it, slide back, please. Stop, slide forwards a little bit, stop. After we've advanced it to 5 millimeters, which is 50% of his maximum protrusion, we lock this screw, close your lips, and we check for comfort. There should be no pain in this area. There should be no TMJ pain. He will feel a little bit of a stretch. Are you feeling any pain right now? Are you feeling your muscles being stretched? All right. So we are good with this position. This is the minimum advancement that I'm going for. It's 5 mm for him, which is 50% of his maximum protrusion. Once I have tightened this screw, I can remove the George gauge. And this is the fixed reproducible measurement that I've got. Now we have his reproducible protrusion open. We are going to put it in the mouth again. Bite, please. Bring your jaw forward and bite. Perfect. Now he's biting in the advanced position that we've fixed. There are two ways of doing this. Either we take an impression with bite registration, which we will do right now. We will extrude the bite registration paste so that the lab can create our device. Close your lips. Once the bite registration paste has set, we can remove the entire apparatus. Open, please. Once we have the upper and lower models, we set it, mount it, and make the appliance. The upper and lower scans have been done. The George gauge is reinserted into the mouth, and a scan of the protrusive bite is done. It's important to note that sleep appliances must be titrable, because when we advance the mandible initially, it should not be more than around 50%. I like to keep it to that. Later, we can always increase the advancement once the patient is used to the appliance. Secondly, 50% or 70%, these numbers are arbitrary. As I explained, if we do a full biometric analysis with joint analysis and muscle EMGs, we know exactly where to place the mandible so that everything is comfortable for the patient. But here we are making an arbitrary reading and measurement. 50 to 70% is not something fixed. So we have to keep patient comfort in mind when we are advancing the mandible. Once the appliance has been given to the patient is told to wear it for a few days. And once they get comfortable, then a sleep study should be repeated. Why are we repeating this sleep study? Because we need to be sure that there are objective measurements to tell us that the sleep appliance is working. The AHI should adequately come down. Oxygenation should significantly increase. Once we know that this is happening, we can say that we've managed obstructive sleep apnea adequately. After giving the patient a sleep appliance, it's important for them to do some mobility exercises in the morning after removing the appliance. These are very simple, gentle mobility exercises of opening and closing the jaws and moving the mandible side to side. And it should just be done gently for a few seconds every morning. So dental sleep apnea is treated in multiple ways, but dentists play a large role. As I said, retroglossal and retropalatal areas are the very common sites for obstruction and restriction in the airway. So know the signs of sleep apnea. We as dentists are very well equipped to find those and report those. Don't be scared of making a sleep appliance. Collaborate with dental sleep medicine specialists, sleep medicine specialists. Collaborate with ENTs and pulmonologists and GPs. Make sure that you are doing ethical work, but don't be scared of making sleep appliances.